So I just want to say thank you so much for everybody for joining day 3 of our virtual wellbeing festival. Really pleased to have you, really pleased to see everybody. My name is Dawn and I'm going to be facilitating the session today. And the session is around suicide awareness and prevention. So I just want to give you a little bit of an idea of what the session is going to include. So this is around increasing awareness and promoting prevention of suicide, asking the questions, is suicide predictable or preventable? Myth busting some of the common beliefs and language around suicide, sharing statistics on the scale of the problem and local and national prevention initiatives to reduce suicide and support people affected by suicide, such an important topic. There'll be an example of lived experience to provide an insight into how suicidal thinking can be overcome. And everyone will be invited to make a pledge on how they can reach out and increase their contact with people in their lives that are affected by suicide. So just to let you know, in the background, I am going to be supported by Anne and Louise, and they will be just helping out with popping links in the chat box, etc., etc. And in terms of a little bit of housekeeping for you all, just to let you know what from a screen point of view, your cameras and your microphones have been disabled for now, but they will be turned back on at various points. You can use the chat function to add your thoughts, comments, or ask questions. Alternatively, what you can do is use the raise your hand function if you have that on your device, and you can do that at the appropriate point and come onto camera to ask your question directly. If you don't have that option, if you're dialing in from your phone, for example, what you can do is just pop into the chat box that you would like to come on camera and ask a question yourself, and we'll be able to do that for you. In terms of breakout rooms, we are going to be using breakout rooms in this session. And when we move into those breakout rooms to enable better conversations for you, you don't need to do anything. So the magic of Teams and the support team behind the scenes are going to whisk you through to those breakout rooms and then bring you back again at the appropriate time. Occasionally, a little bit of technology happens and people may not move into those breakouts, but they'll stay in the main room. If that happens, don't worry, we will get the support team on that and they'll be there to help. For colleagues that are hearing impaired, you can turn your cameras, start again. For the hearing impaired, you can turn your live captions on by clicking on the 3 dots at the top and then clicking turn on live captions. This is only enabled on computers using the MS Teams app, so unfortunately it isn't a feature on phones or iPads. Now next, what we'd like you to do is we'd like to do a little bit of a test for Slido, because we are going to be using Slido throughout the session. Louise is going to post a link to the Slido into the chat box for us now. However, what you can do is, if you have generally an iPhone or a very up-to-date Samsung, for example, you can just hold your camera up to the QR code that you can see on the screen and it will take you straight through. The question in Slido, as you can see, is what you're hoping to gain from this session. So we want to use it as a bit of a test, and then later on we will be continuing to use Slido, so you can keep it open and it will naturally move on as the question pops in. So if I can get you to try logging on to Slido for us now and just answering that question. Fantastic. So we've already got ways to support someone in crisis, how to support people. Brilliant. Better awareness, absolutely. Okay, fantastic. So we'll just give you a minute before we move on. Lovely, raising understanding of how to support people. Fantastic. So it's all about that raising of awareness, increasing our knowledge around the subject matter, how to support other people, how to spot those signs. So that's brilliant. So as I say, as we move through the screens later on, we will be having more opportunity to use Slido just to ask a few questions and find out our thoughts. However, what I would like to do now is to be able to hand over to our team that are going to be taking us through the subject matter today. and that's Phil Broxton, Andy Willis and Lisa Pearson. So please come on and introduce yourselves. Thank you very much.
Lovely, many thanks, Dawn. I'll start off just because my picture's on there first. So I'm Phil Broxton. I'm a senior practitioner and a registered mental health nurse by profession. The reason I'm here today is to, hopefully to support some of those things that people have expressed that they'd want from today's session. It's a subject that I'm really passionate about. Sadly, I've been affected and lost people through suicide all my life, from friends, colleagues, people that I support, etc. So yeah, I'm really chuffed to see that there's lots of people here today from different services, teams and families as well, to raise your awareness and improve prevention. Great, I'll hand over to Andy.
Yeah, Andy Willis. I'm a former service user, also a member of the Personality Disorder Lived Experience Advisory Panel. My joint diagnosis is emotionally unstable personality disorder and recurrent depression. 4 of my 6 episodes of severe mental illness, there was a significant presentation during crisis of psychosis, which obviously adds to the risk. And I bring the lived experience of 7 attempts to die by suicide, 2 in the inpatient setting when I was 27, and 5 at the age of 53.
Thanks, Andy. Good morning, everybody. My name is Lisa Pearson. I'm currently the suicide prevention lead for the Trust. I've also similar experience, been bereaved by suicide, and I'm a suicide survivor myself. Part of my role, which is a new role, is really to look at how we can create awareness of suicide and also suicide prevention. So the Slido information you gave out is really what this session will be covering. I'm also going to be covering the chat today, so I'll take myself off camera in a minute. If you have any questions, please do not hesitate to ask them. I will try and answer them. If not, I will come back to you. And if you feel at all in distress and you're needing some coping strategies or where to go, I'm also there to support you through this session, because it can be quite a difficult topic. Thank you.
Great. Next slide, please, Dawn. Our details, my email address is there, and just to one of the questions that normally comes up is whether people can have copies of the slides, and absolutely, I want to be able to share these slides with people. There are some links within the slides which people can access today, but I'm more than happy for copies of these slides to be sent out with any of the details on, so don't worry about taking notes. You can have a copy of the slides, and you can contact me if you want to clarify anything. Thanks, Dawn. Next slide. As Lisa said, the subject we're talking about today is really emotive. So there's a number here for people to contact alongside using the chat function. And towards the end of the slide, I'll be sharing some local and national services that are available for people, through telephone, text, internet. So there are other places to visit. So there are ways of the people here getting support today, and also sharing that information with your nearest and dearest. So yeah, next slide, please, Dawn. So yeah, today what we're hoping to do, again, we've got a brief amount of time. Myself and Andy are used to doing this over a morning time, really. So we're trying to cram in as much information as we can, because it's, as I said, it's something we're really passionate about. So we want to increase awareness about some of the factors that make people more vulnerable or to being affected by suicide, thinking about the signs and how to improve access, thinking about prevention strategies. And this is an expression that I saw when I was sort of preparing for this. We want to be able to ask, explore and keep safe. So that's something I'm going to keep referring to, or in future. I think that's it's a really nice way of thinking about it. And also, I was really keen, this is a wellbeing festival, so it's about our own well-being, but it's also about the well-being of the people around us. So, and that's why I was thinking about making a pledge to support the people that are affected by suicide. So we're moving on to the Slido now. The breakout rooms, isn't it? So we've got a breakout room where we're going to put you into threes. So it's an opportunity for you to think about whether you think suicide is predictable. I want you to have a conversation. You'll be put in a breakout room for 4 minutes, and as part of that, if you can use the Slido, you can put your thoughts down on whether suicide is predictable, or if you're unable to use Slido, you can use the chat function. Looks like everybody's back, so thanks for joining the breakout rooms, and hopefully, I know some people it takes a bit of time to get in there and to get back, but everybody looks like they're back, so that's great. And just picking up on people's thoughts, ranging from, you know, it's not predictable, through to sometimes, or it may be. So again, you know, part of what we're going to cover is whether we can think whether it is predictable or not. So yeah, thanks for sharing your thoughts. And one of the questions, predictable for who? It was you know, whether we can predict it. The people that are here today, is it predictable? Yeah. So yeah, and if you can move on to the next slide.
Is that showing, Phil?
Yeah, so we're thinking about risk and the risk of suicide, and you know, if you move on to the next slide again, Anne. Question in Slido is, using clinical risk assessments, how accurate do you think they are at predicting suicide? So are they 0 to 25% accurate, 26 to 50, 51 to 75, or over 76% accurate? So when we're doing risk assessments, you know, with those questionnaires, etc., how accurate are they in predicting whether somebody may die of suicide? And again, if people aren't able to use Slido, if you just want to put something in the chat. Just going to open the chat to see what it's saying in there. Yeah, not very accurate. Thanks, Kaj. Okay, we've had some responses there and some feedback. So most people thought that they were going to be 26 to 50% accurate, and the number of 0 to 25 is shrinking, or that's going up to 61%. So the actual research that Rav Kapoor did, who's from Manchester University, he found that risk assessments are 5% accurate. So, you know, so then it leads on to the question, why do risk assessments? And what Rav feeds back is, when he shares this with clinicians, they say, well, you know, if there was one risk assessment that we should use, which one would it be? And he's saying, well, actually, they're not accurate at all. And there are ways that we can assess or prevent suicide, which we'll come on to later. So thanks for sharing your thoughts on that. And again, Phil, you know,
I'll just
yes, Andy.
From a service user's point of view, I recognise why clinicians need to have a risk assessment for all sorts of professional reasons or whatever. From a service user's point of view, you become aware when one is being done, and you can deceive. But I guess what I'm saying is that, from my point of view, the key thing is a safety conversation. And I personally believe, without having any clinical background, you can arrive at a risk assessment through an engagement of what a person is feeling, emotional thoughts. You can build that safety in and reduce the risk and make the risk assessment. Obviously, this is sometimes the start of the trains.
Yeah, thanks, Andy. Yeah, so it's about safety planning. That's what we want to talk about or think about, isn't it? Rather than, yeah, doing a risk assessment, looking at somebody, you know, a safety plan's done in collaboration, which we'll come on to in terms of the prevention. So if we can move on to the next slide, please, Anne, and hand over to you, Andy.
To me.
The next slide, Anne, is Andy's lived experience.
Have we not got the preventable first, Phil? the question on is suicide preventable, I believe, is next.
I beg your pardon, if you just go back one, Anne. So is suicide
Okay,
preventable?
back on.
I think this one is just a Slido response, and that's it. It's coming up.
Brilliant. Every life is worth living, definitely. Living the absolutely getting big. Brilliant. Lots of yeses. Really positive. If you have the right tools, yeah, brilliant. And the right support. So it's about tool. We're noticing we need the right support. We need the right tools. Great. Yeah, just picking up from Kelly, yeah, there's so much more that can be done nationally and earlier in schools. Yeah, absolutely. CAD, yeah, you think it's preventable. Brilliant. Yeah, so really positive and hopeful that everybody's thinking that it is preventable. So that's perfect. Great. Okay, thanks. So we're going to move on now to hand over to you, Andy.
Yeah. What I want you to do, I'm going to shape out the lived experience around the first attempt I made on my life, and then shortly after that, the second one. And I want you to consider those two questions. We won't have time for lots of feedback, but just think in both cases, as if you like, as the picture builds. Was it predictable? Was it preventable? The context is 1986, a long time ago, so there's even more prejudice, discrimination, myth around mental illness. And to be fair, I held my own unconscious beliefs about that. You know, I had no insight. It was my first episode of severe mental illness, so I had nothing to counter any of the thoughts. And in the people around me, and my parents equally, there was no experience of mental health in the family. In brief, the background, if we're looking at the January of '86, I was in my 5th year of teaching. I was a very driven individual. There was a bit of the perfectionist about me. I had no work-life balance. I gave everything to teaching. I burnt the candle at both ends. I thought I was physically and mentally bulletproof. It's fair to say that as an individual, I kept my emotions to myself. I didn't share difficult emotions. I was a very closed person. And I guess that where things started to change, and if you like, it's the beginnings of losses at the time, between the January and April, I'm talking now, there was changes at work. A new head of department. What I perceived as years of work was going to be torn up. But there was that coming to terms with. A number of colleagues who felt similarly were leaving. My nan, who I was very close to, was diagnosed with terminal cancer. The first truly meaningful relationship I'd had was at distance. She lived in Liverpool. And that was coming under pressure as I now recognise I was getting more anxious. My mood was dropping. The trigger point came in the April where I perceived if I could get a new job, all would be okay. I hesitated at the interview. I probably wouldn't have got the job anyway, but that was a trigger. And all I can say, I felt like my mind and my body were like detached. And that was the beginning of a quite rapid decline, which I masked. I was struggling daily, but I carried on teaching for a term. Huge anxiety when I didn't seek any support. I didn't go to the GP. I thought if I could just get through to the end of term, but there was a real intensity of emotion, which I now recognise as part of the EUPD, the unbelievable sort of, I thought it was incurable. I started to perceive I'd end up being locked away, what I regarded as the asylum, that type of thing. There was all these thoughts going on. I thought, if I can just get to the end of term, all be okay. The type of things my mum and dad, bless them, I remember some of the cliches where my mum said, "Put yourself together, son." There were lots of other inputs like that. They were frightened. I was frightened as well, to be fair. One colleague at work said, "This will finish your career." They took me to one side and said, "You're not well, are you? It's near the end of term. It'll finish your career." And for me, all I could think was that if it didn't go well, that would be it. I was having suicidal thoughts by about the late June, and then in the July I was put on some antidepressants before we went away to a holiday with my girlfriend. That I perceived it didn't go well. I was hiding the suicidal thoughts. I asked her to marry me. That didn't land either, and I thought, that's it. I started catastrophizing, and in short, when I got back home, a friend effectively saved my life. He took me to St Andrews. I don't remember much of the consultation. I do remember that they weren't going to take any payment, which I perceived as meaning I had no hope. And I went to Addington, which was a locked ward at Kettering Hospital. And I thought, if I could just get some sleep, I'll be okay. I noticed the locked windows, the locked doors. I've never had an inpatient experience, obviously, before. And I thought, this is it. There could be quite disturbing places. And I thought, I've just got to get to sleep and get out of here. In the morning, I only slept about 2 hours. I had already seen the means to end my life, and all I can remember, it was around about mid-morning. We went to a community meeting. I didn't appreciate how unwell other people were. There was virtually nobody said anything. My thoughts were tormenting at the moment. There was a religious dimension through the psychosis, that I would perceive myself as a sinner. I was going to go to hell. The thoughts were unrelenting and persecuting. And I remember getting up, walking across. The only comment I made to one of the nurses was, "This isn't very therapeutic, is it?" And I walked down to the end bay, and nobody came with me. There was one patient in the end bay, and I thankfully perceived that they would be not able to do anything. I think I spent about 45 minutes writing a suicide note. I then waited until the community meal, or wherever it was. I knew it was. I'd seen the canteen stuff. It was further down the corridor, and the last thought, I've never had racing thoughts like it. The last thought the trigger thought of volition was, "You're going to hell. God is telling you to take your life. This is your test, and if you do, you'll go to heaven." And so you've got to ask yourself the question, with that backdrop, was that predictable to anyone? Was it at any stage preventable? The next attempt on my life this is much shorter. I'm obviously mindful of the time. I remember becoming conscious. I was on what I now recognise as arm reach observation for about 8 days. I still had suicidal thoughts. I still had what I now recognise as psychosis, if you like. I wasn't sharing anything. Of course, there was support by the clinicians, but there was never any conversation about what had led me to that place, 24 hours before. And I was planning from that point. It was probably about 3-4 weeks later, I was becoming incredibly anxious, and I felt like I was physically dying. And I worked out that if I could maintain enough concentration in the OT sessions, I would be trusted to go out on a community walk. A couple of factors that were coming in. I perceived I was going to lose my job. I had no idea of employment rights. It wouldn't have been the case, but I thought, if I don't get well by September the 2nd and back to school, which was totally unrealistic, I'll lose my job. So that was in there. They were obviously, the staff were opening mail. There was a letter from a girlfriend. I remember giving it to me, and in that letter, when I read it, it was confirming that the relationship was over. And for all those thoughts, it coincided that I was trusted to go out on the community walk, and that's where I made the second attempt on my life. And I would ask you again, in that second occasion, was it predictable? Was it preventable? And in my own, when I reflect back on that, probably the first attempt on my life wasn't predictable. Probably wasn't preventable. Who knows? There's always opportunities. Of course there is. The second one, my own belief is that yes, it should have been predictable and it should have been preventable. Smile for the time, Phil. If I waffled.
No, not at all. That's
I mean that's the context of two pieces of lived experience. Obviously, a little bit of a different time in the 80s, but that said, there is still the challenge today of prejudice and discrimination in mental health. And my word, there is around the stigma of suicide. It has to become open conversation. That's all I would add in, which obviously Phil will pick up in a minute. Thank you.
Yeah, no, thanks so much, Andy. Yeah, for sharing that with us. And I know we've gone through this. We've discussed this a few times, haven't we, together? So yeah, it's still really impactful. So thanks for sharing that. Yeah, so you're getting some feedback there, Andy. People are really appreciative of you sharing that information. So thank you. Can we move on to the next slide, please, Anne? And again, you know, hopefully we'll be able to pick up any questions at the end, or people can start putting in any questions for Andy that we can pick up. So for me, one of the trends that I've noticed since I've started studying suicidology years ago is that men are higher risk of dying by suicide, and that cohort of men is sort of it's currently middle-aged men are at the highest risk. And you know what has changed, this is the latest report come out this year from Manchester University, and this is about men that died by suicide in 2017. And what is more positive now is that more men are getting support or having contact with services, because that's something that's been really difficult in the past. So this is sort of highlighting that of those that died by suicide, lots had contact with the GPs, only half had contact with mental health services, some with the justice system, less with substance misuse services, and some with employment services. So again, in terms of it being preventable, it's trying to, as people have already highlighted, having the right tools and the right support to intervene within those services. And there's some recommendations on here about services needing to recognise risk, know how to respond to men's needs, and you know it's about working together. So you know today we've got representations from lots of different services and teams that we can all work together. Great. Next slide, please, Anne. So again, you know, people mentioned earlier about risk factors and they're dynamic. So this is highlighting, you know, what those risk factors are for middle-aged men. So having a mental health diagnosis. So that's, you know, 2/3, which shows that a third didn't have a mental health diagnosis. Physical health conditions. So again, you know, that's a big factor. You know, if we know people are suffering from their physical health, that could be an indicator. Drugs and alcohol use. Half the people affected, that was a difficulty. And bereavement, that's something that's been picked up sort of more recently, and this sort of refers to men that have been bereaved and you know one of their parents have died. That's a factor. And also suicide related internet use, so that's something that's become more apparent, really, more accessible. People looking for ideas and ways of ending their lives on the internet. And again, you know, we'll come on to that as part of the prevention later. If you can move on to the next slide, please, Anne. So I've talked about middle-aged men. There was research commissioned to look at a trend of female nurses dying by suicide, which was seen as something that's been increasing, and you know there are bits missing out of the research, and there's a request for further research to be done because some of the data is a bit patchy. But I found this really quite alarming, really. So this is showing you know, from the period of 2011 to 2016, the darker columns are female nurses that died by suicide. And again, you know, as part of the care partnership with, you know, we may have some female nurses here today, or certainly, you know, some of us be working with middle-aged female nurses. So again, you know, thinking back to, is it predictable? you know, this is showing us the sort of risk factors, and can we prevent that? Okay. Thanks, and if you could just move on to the next slide. So thinking about the rates of suicide in England, and again there is data available for Wales and Scotland as well, but we're just focusing on England today. So I've highlighted Northamptonshire. So on the left hand side, you know, you can see the rates from low rates, and then as the colours get darker to the highest rates, and you can see in Northamptonshire we're about 3/4 of the way, you know, in the highest ratings of people dying by suicide, and this is 2016 to 2018. And again, going back to that question, is suicide predictable? You know, if you look at that map, we can sort of predict the levels of suicide in those different areas, and you know, so that sort of highlights where we should be thinking about prevention measures. And if we move on to the next slide, please, Anne. Down, so in Northamptonshire, you know, where are people dying by suicide? You know, we have that data, and this is showing, you know, the grey is 2014 to 16, and then the blue is 2017 to 2019. So you can see in some areas there's been reductions, in some areas there's been increases, but the highest bar in 2014 was in Corby. So again, you know, that's an opportunity for us to think, you know, what's happening, where are people dying by suicide, how are people dying by suicide, what measures can we put in place to try and reduce that? And it looks like there's been something's happened, and they have been reduced, which is fantastic. I'm just wondering, are there any questions that are coming up? I'm just checking the chat.
We've got one question about where would trauma fit in with those risk factors for middle-aged men. I don't know if you want to answer that. My comment on that would be that it's an overview, and if somebody isn't diagnosed with trauma because they're obviously scrolling through all the information, then we wouldn't have that information for that report necessarily. But that's not to say that trauma is not informing because of a bereavement or drugs and alcohol. Would be my answer. Phil or Andy, have you got anything to add to that?
I'd add that, yeah, certainly. I know the data shows that people that have been affected by violence as well, their risks of suicide have increased as well. And yeah, if they've been subject to any trauma, then yeah, that would increase risk, definitely.
The only thing, yeah, I would agree. I've obviously got no clinical knowledge, but supporting somebody who was in a real crisis situation, part of the negativity of the thoughts were flashbacks to some really stark trauma-related stuff, to particular incidents in late teens, and I can only say that would just add to the burden. It would add to the, you know, the intensity of emotion. I think, you know, if you've got trauma being taken on board and being supported or reduced or coping with it, can only be something very important to prevention.
Thanks, Andy. And just picking up the question about why are there certain areas in England that are higher than others. Again, there's lots of socio-economic factors that have contributing factors. So there's unemployment levels, can be access to means, can be different. So sometimes we see in areas of the country, so on the coast, etc., where there's, you know, there may be high levels of unemployment, etc. They're certainly factors. So I hope that answers your question.
Yeah. Can I just add to that and say that if anyone there's a really good Panorama documentary about men and suicide, and they really do quite a big look at different pockets of areas and why that might be that there's certain higher suicide rates in different areas. So if anyone's interested, that's definitely, you can get it on iPlayer. It's definitely worth a watch. And is there a link with people suffering from money pressures?
Absolutely, yeah. It's one of the factors. The report that I've shared from Manchester, if people go onto that, you know, one of the factors is financial difficulties. So again, you know, we know with COVID and people being made redundant, you know, that's certainly a factor. Yeah, that, because again, for middle-aged men, you know, having that thought and responsibility of, you know, needing to look after the family and pay the bills, and if they can't do that, then that certainly increases the risk. So again, that's something that we can predict. Move on to the next slide. So what about the impact? So this is again startling information. By the end of this month, by today, this is in England, 385 men would have taken their own lives, and you know this affects directly or indirectly 135 people, so over 50,000 people, and of those 65% are more likely to attempt suicide than if those people had died by natural causes. And again, in terms of, you know, at any one time 20% of the population are thinking about suicide. So again, in terms of preventing suicide, so this is why it's really important to be able to think about supporting those people affected by suicide, because if they've known somebody that's died by suicide, that increases, that certainly increases. Yeah, sad face, Suzanne, absolutely. So move on to the next slide, Anne. So we've thought about awareness and hopefully, you know, shared some information about some of the statistics, and there's lots more statistics that we could share or think about. But you know, we're moving on to thinking about prevention. So again, this is based on the middle-aged men. So thinking about adopting intervention to suit men's needs. And again, we'll sort of talk about local and national plans, but you know, having things like men's clubs and men's groups are really helpful, and that's happening within the county, which is great. Safer prescribing, so again, that's sort of educating GPs, and there may be GPs here today, or maybe watching this at a later date, about thinking about how they prescribe medication and access for people to have medication when they come into contact with services. There's also recognising risks after self-harm, which we haven't, you know, sort of mentioned, but you know, there is, again, in terms of predicting risk of suicide, there's a massive link between somebody that's self-harmed and then died by suicide, and it's been within the last few years that there's been the sort of nationally recognised links between self-harm and suicide, and NICE guidelines sort of produced based on that. The other factor is about bereavement support. So again, we've got things that are happening locally. We've got We Mind and Kelly Matters, which I'll talk about later, but it's about offering support to those people affected by suicide. So thinking back to those early statistics, you know, 62% or 65% of the people that, you know, are affected by suicide think about suicide. It's really important that they're offered some support and opportunity, to talk about their feelings and talk about their experience and their loss, which is massive. And then thinking about improving online safety. So and there's a lady, Alice, who sadly lost her brother to suicide 6 months ago, and she's been really motivated to prevent that from happening to anybody else. So she's developed some software called Ripple. Again, there's a link to that within the presentation, where if people are actively searching for means of suicide online, something will pop up and sort of direct people to support. So sort of, again, an opportunity to sort of increase prevention. If we move on to the next slide, please, Anne, and hand over to you, Andy.
Yeah. I'll shape out some, hopefully some insights. What I'll say from the outset, suicide is very individual, very complex. This is only my lived experience, and it's not a blueprint, but I hope that in the end of the next 10 minutes, there will be some insights where if you're with somebody, it may give an indication. I'll shape out for me that I can identify 4 clear stages. In terms of top tips, I mean, these will be ones that many of you will have in your own mind as well. The most important thing for me is you build prevention by building support as early as possible, and it's that idea of talking about mental health, but talking openly, asking the question, whether it be within families, whether it be in the workplace, in community settings, anywhere really. Don't be afraid to simply ask somebody, are you thinking of self-harming yourself? Are you thinking of dying? Are you having suicidal thoughts? And ask them twice. It's how you ask. Be mindful how you ask that question. But it doesn't matter if they say, no, of course not. You've asked the question. And if they say, well, yeah, then you ask, are you planning? You have, that's for me, that's one of the most important things. If you can change the culture, that you've got a chance, a much bigger chance. I think also whenever you're having conversations with someone, for me, one of the biggest factors was a lack of hope. And no matter how distressed somebody is, no matter how much the problem seems insurmountable in their life, to give them that hope that they can get to a better place, and they will get to a better place, and they can recover. And there are people there that will listen and support. That perhaps it's an obvious thing to say, but you can take people out of that suicidal way of thinking at any point, and that's really important. I think also for me, even when you're well, if you can identify one or two people in your life, it may be your family, it may be your friends, it may be a clinician that you can turn to if you have suicidal thoughts, if you're like a safety buddy, and it could be someone who you eventually share a safety plan with, that is key. Because if you've got somebody who you can share with, you build in prevention. I think also, it'd be a good idea for everyone to have a wellbeing plan, but I fundamentally believe that everybody should have some sort of safety plan, even if they've not had any thoughts. Just the contact number, whether it's the integrated hub, awareness of the crisis cash, somebody who they would turn to, what harm can that do? That would be equally very, very important. And I think the other thing that I would say is also important, if you're well, write down a statement about how precious life is. Write down a statement of the people that are important in your lives, because if you've got some sort of protective feature, you may, if you're in real crisis, you lose that side of that. But that's an important aspect as well. In terms of the 4 stages, and I can only speak from myself here, I've described quite a lot of the symptoms, but if one of them is the awful distress in your mind, and I'll just simply punishing thoughts, deep depression, locked in the past, aspects of psychosis and sort of delusional thinking. Obviously, there's always the possibility of impulsivity if you introduce alcohol and drugs in there, but that negativity, that feeling of being incurable, that feeling of having no hope, that feeling, intensity I experience of emotions are unbearable. And that is the backdrop for me, wanting to get some respite and end to those thoughts, those emotions. That's the backdrop to the 3 stages, or 4 stages, sorry. The first one is before suicidal ideation, and I can remember thinking and actually saying to people, I just want it to stop, just want to get away from it all, just want to sleep, just need a rest. That for me is the shaping out of the beginnings of suicidal thinking. And when I look at it, I might pluck out of the blue, instead of being a teacher, I just want to be a postman. If I can just go somewhere in the country, just get away from it all to a nice, field, and it all will be good. Of course, you take your thoughts with you. If I could just think, for me, it would be again a religious dimension sometimes, because of the presentations of later psychosis. If I could just go to a religious retreat, cut myself off from the world, become a better person or whatever. And any of that, if anyone is talking around that type of area, I would suggest you ask them the question, get them to the GP, get some support for them. The stage 2, and there's no time frames on any of these, but the stage 2 will be suicidal ideation. And for me, it would be marked with, I'll be having very morbid thoughts. I'll be preoccupied by death. I might present as very tearful in this stage. I would perceive that I'll be doing things for the last time. I wouldn't be planning for the future, because already I'm thinking there may not be a future. My language will be very negative. Sometimes I'll reference in the past tense. I would certainly be considering, I might give away I'm being punished or I'm a bad person. But in this suicidal ideation stage, I would be thinking about suicide. I would be thinking about different means. You start to draw into a planning stage. I would often be on the internet. Is there a quick way? Is there a painless way? This sort of nonsense. There's neither anywhere around that thing. I gave away, in my last extended episode, around the suicidal ideation stage, I gave away my 2 Chelsea scarves to my daughters. Somehow, in a way, subconsciously, they'd remember me. I gave away my darts to my son. I remember giving away a couple of T-shirts. But if people start giving things away, it might be in this stage that a loved one puts things in order, a will. I didn't do that. But I remember also someone had done some building work for me. It was mates' rates. I had a year to pay it back. I paid the money in this up front. Got it because somehow I thought I don't want to die without leaving a debt. obviously the third stage is the planning stage, and you can move from ideation to planning quite quickly. In terms of that, I would be very isolated, very reserved in myself. I'd be presenting as being anxious. I would certainly be very little conversation. I may look a bit fearful, agitated. I would be in all or nothing thinking. I would be seeing myself as a burden to others. And in this planning stage, I would be deciding a method. I would be planning. I would be perhaps going to the venue, sort of a rehearsal. I would have often a time in my head, and I would see it dangerously as a resolution to my problems. I guess what I had expressed to people in this planning stage might be around ideas of being possessed or going to hell. That would be the psychosis type thing. On one occasion, I said I want to end it all. In terms of contact with services, it was a seesaw. I would still be wanting, there was still some indecision, fortunately, and I would say something along the lines, I just want to get me somewhere safe, get me in the hospital, I need to go somewhere safe. And then in the next, the yin and the yang, on the risk assessment, they would ask me, are you suicidal? I'd say no. So it was a massive challenge, and it was that seesaw that made it so difficult, and I would be into deceit, because I would be perceiving, my mind would self-justify everything, and I would perceive that my children would be better off without me. I may, in conversation, be expressing sorry, but there'd be less and less signs. Again, in both of those stages, the ideation and the planning, particularly the planning, get in the company of somebody, ask them the question, get them to the crisis CAFs, get them ringing, get them getting support if they haven't got any. And the final stage, if you like, the volition, this could, the time in between planning stage and volition, it might be hours, or it might be, as I described in the previous lived experience, weeks, a couple of weeks. And all I would say there in the stage 4, I would have made a decision, I would be focused, my mind would be justifying everything. I would be, as I mentioned, lying, deceiving, making sure I had the opportunity. I always remember a numbness of emotion at that point, no fear. And as I say, a sort of a resolution. How I would present to others then would be actually the mood's lifting a bit, seem a bit calmer, seem a little bit less anxious. As you get a bit better, and it would be a long, long way from the truth. In terms of this, any other presentation, apart from somebody coming across me in public, for example, because often it would be in private, where if you like to attempt to die. I wrote on two of the attempts I did write suicide notes. The one thing that saved my life, on one occasion, I sent a text to my sister, the only one I sent, and it was in the past tense, and that was the difference. All I would say is, you have always got an opportunity to support. You've always got an opportunity. You have to ask, you have to be mindful, you have to support people. As an individual yourself, when you've got some insight, you've got to be reaching out for help before you get to the latter stages. And equally, I appreciate there are all sorts of manner of different reasons and different pressures, and it's such a complex topic. My last point would be, when I reflect back, I know how precious life is. I know the impact I would have had, the ripple effect that Phil spoke about, and that's why I'm so passionate about this. It's such a crucial thing, because life is precious. It can be prevented. You can build in predictability to a degree, but it's immensely complex, immense challenge. Okay, sorry about the timing, Phil. I was mindful of the time.
Perfect, Andy. No, I think what you say is so important, and so helpful. Generating hope and talking about opportunity is absolutely fantastic. So I really value that. So thinking about that ripple effect, like you said. Thanks, Andy. If we can move on to the next slide, Anne. And thanks, Lisa. I can see you've been answering some of the questions in the chat. So that's really good. Again, this is This picture on the right is from the campaign against living miserably. So this is about what things that people can do, that we can do. We can ask, we can listen, we can take action, and we can network. So there's some real key tips really on things that we can do. Yeah, and I'm just noticing things coming up in the chat. Just thanking you for what you've shared, Andy.
In one, I appreciate it. Just in one line, I think I'll only say one more thing. I think I've probably already said it, to be fair. When somebody asks the question to you, it doesn't trigger thoughts in your head. If they're there, they're already there. It doesn't make the situation worse. It actually presents that somebody cares. And the one thing I did miss, which was very, very important, even in those last minutes of that volition, if you saw anyone, for example, a train station, if you can still take the person out of that place by the appropriate conversation and reassurance to listen and support and get them safe. Even at that, it's never too late.
Yeah, and I just wanted to pick up as one of the points you were saying, Andy, about it being complex. It is really complex, and there's a volitional model with lots of different factors that can lead up to it. But the other way of thinking about it, there's lots of opportunities to intervene. That's how we can think about it.
Yeah, 100%.
Yeah. Next slide, please. I'm just realising we're coming to the end of time. We haven't got many slides more to go through. So what are we doing? These are 10 things that are happening, that are recommended to help prevent suicide. So ranging from safer wards, having early follow-up on discharge, reducing the number of areas of out of area admissions, having 24-hour crisis teams, family interventions in terms of learning lessons. So again, thinking back to that, people affected and bereaved by suicide. Guidance on depression, how to treat that effectively is really important. Personalised management plans or safety plans, as Andy's made reference to, having outreach teams, trying to reduce staff turnover, and having dual diagnosis services, so drug and alcohol services. So these are the things that are sort of recommended nationally, and I think locally, you know, we're taking action on all of these areas. And there's a QR link there for access to the safer service toolkit, which people may want to look at. Next slide, please, Anne. So I've mentioned some of these things already throughout the presentation, but you know, it's great that Lisa's the suicide prevention lead for the county, which is fantastic. I talked about men's clubs. We've got wellbeing CAFs. We're doing training. We've got mental health first aiders, so that's really good, raising awareness of mental health and supporting people to get support. I saw on one of the other presentations this week in the Wellbeing Festival is the talking session that they're doing at Kettering. If we think back to female middle-aged nurses being at high risk, having those types of opportunities is going to be really helpful. Yeah, and lots of other things that we're doing in terms of offering different services, DBT. Nationally, we've had a suicide minister appointed, Nadine Dorris, and there's also the Zero Suicide Ambition and Alliance. And next slide, please, Anne. And these are some of the services that I've made reference to, and there's a link in the presentation to go to the Ripple Suicide, which has a database of all the services that are available. And as I said at the start, some of these are, you know, through text, some of them are via the internet, so chat functions for people that find it difficult to use the phone. The hands there is Saving Lives, which is an app. So there's lots of things that people can access, and we can sort of direct people towards, or let's go alongside people and help them to access these things. And we've got the We Mind and Kelly Matters logo there on the bottom right, which is you know, a local charity that's been set up to support people affected by suicide, and also, you know, affected people who are thinking of suicide, and they're doing lots of campaigning. And yeah, the Ripple logo's on there as well, which is, yeah, doing lots of campaigning to improve internet safety. Next slide. The last question that I've got for people to think about is, you know, based on what we've talked about, what pledge can you make? to either increase awareness or increase prevention. So I'm just going to read something from Rory O'Connor, who's done some fantastic work from Glasgow University. So creating hope through action signifies the resolve to impart a new sense of purpose, empowering and equipping peoples with the skills and confidence to connect with somebody they think may be struggling. So, you know, creating hope through action. And going back to the slogan I said at the start, we need to ask, explore and keep safe. So if we could go on to the slide and give people the opportunity to make a pledge. Yeah, what is your pledge to reach out and support someone you know or who may be affected by suicide? Brilliant, don't be afraid to ask the question. And I'm mindful of the time. If people need to leave now, then thanks again for spending your time to come and learn more about awareness and prevention. And you know, do get in touch if you've got any questions that you haven't had the opportunity to ask.
Yeah, thank you.
Yeah, being brave to speak to others. Really listen to what people say. Yeah, and one of the things is it's not about problem solving, is it, or finding solutions straight away. It's just about being heard and being understood. You know, if people have had a difficult time, you've had a difficult time, it's understandable why you're really upset. I'm going to try and solve problems straight away. It's just having that opportunity. So somebody's going to ring a friend who's had a breakup. Perfect. That's a really good pledge. Yeah, not being worried about triggering suicidal thoughts. Yeah, because that's one of the myths really that will make things worse if we ask people. With the evidence shows that's not the case. Yeah, knowing you can talk about your mental health. Yes, please do talk about your mental health. It needs to be talked about. Yeah, thanks for the feedback in the chat. Kelly, I've seen your name come up a few times, and Suzanne, brilliant. Lee, thank you. Saw Clean's name pop up there. Nice to see you, Clean.
Can I just say as well, you know, if there's something that you're interested in learning more about, there's lots of opportunities locally to access more training and more awareness. So if anything is interested, certainly if you're within the trust, there's training in-house in NHFT, but it's also training in our locality as well. So we, My Kelly Matters, offer assist training. There's extras for the mental health awareness, mental health first aid training as well around suicide awareness. So if it's something that's really perked your interest and you're quite passionate about learning more about it, I hope this is a sort of stepping stone for you. So please continue on that journey. That'll be really positive.
Thanks, Lisa. Right, I think we're going to sort of bring it to a close there. So again, just thanking everybody for their time to join us and thinking about this really important subject.
Yeah, thank you. Thank you.
Thank you so much, and I just want to echo what everybody's saying in the chat box. Such an amazing session on such an important topic. So for those of you still with us, I just want to just mention that we are going to put a link to some feedback in the chat box also. Feedback is a gift. It helps us to learn and shape future events around what you're looking for. So please leave your feedback by completing a very short survey. Use the link in the chat or the QR code on the screen with your phone to take you through that survey, and share your thoughts on the session. All feedback entries get entered into a prize draw. You've got to be in it to win it. To win a Virtual Wellbeing Festival 2021 goodie bag with some festival goodies, and some of those may also have some of the books from one of our keynote speakers. As they say, you've got to be in it to win it. So just to remind you of the lineup for the rest of the week. Also, you can go back and re-watch, I'm losing my voice, a lot of the sessions from Monday, Tuesday. So as you can see, everything that we've got on is on that slide there. So please feel free to join any of those. And then, as well as all the sessions available, we have got 3 different challenges for you. So stair climbing challenge, to see how you can challenge yourself by setting yourself a target to climb some stairs. There's a photography challenge, getting outside and taking pictures using your phone, sharing that on social media with the hashtag VWBF 2021. So each day there is a different challenge. So for example, today's look up, tomorrow's look down, Friday's garden, Saturday's nature. So just please keep up to date with all of those. The last one's not really a challenge, more of a call to action for us to create our NHCP wellbeing playlist. So what music makes you feel better? Share your thoughts and we'll compile a playlist to include everybody's choices. Finally, we've also created a digital resource pack, which is being shared by comms colleagues and is also available to download from the website. So please check that out. Let's get social. So on the screen now you can see links for Twitter, Instagram and Facebook. Please share your thoughts, learnings and experience, and please tag NHCP and your own organisations into that as well, using the hashtag Northants Wellbeing or hashtag for the photography challenge, which is the VWBF 2021. So let's get Northants Wellbeing trending on Twitter as we did last year. And then finally, thinking about the sessions that we've got across the week and the session that you've just attended, just want to remind you that support is available to you if you've been affected by anything that you've heard today. So as you can see, we've got our Stronger Together, which is providing wellbeing support to health and social care colleagues in Northamptonshire. We've got our Changing Minds, so the IAPT, for talking therapies to support stress, anxiety and depression, and the mental health number, so the crisis line and website for more information. But on behalf of everybody else, I want to thank you so much for attending today and getting involved as usual. Thank you so much to our speakers, Phil, Andy for your lived experience, and Lisa behind the scenes kind of looking out for and answering all of those questions. And from my perspective, I want to thank Anne and Louise as well for helping out. So thank you so much. Have a fantastic day.